developing specific devices for patients. So, I was having the real notion that every patient is very specific. Every anatomy of each patient is really unique, and each regenerative surgery was challenging me in different situations. So I needed to access the specific anatomy and the specific landmarks of each patient, because everyone would be unique with unique difficulties, unique challenges. So why do we need to be using conventional tools that are not made for each specific situation? So every time I was having a patient and I was trying to see, let me see which tools do I have to treat these patients, and not the reverse thinking of, let me see what this patient has unique and try to fit something specifically for this patient, because every patient will be unique. So what the most difficulties that was having in bone regeneration was the difficulty to adapt graft materials and barriers to the patient's specific anatomy. Sometimes I was having difficulties in cutting the membranes. I could end up with a too large membrane for the defect, or a too small membrane for the defect. I was having troubles in bending and folding the specific membrane to have the proper anatomy of the scaffold, or I was having trouble in adapting the graft material, packing the graft material. It could be too packed or too loose, or not properly excluded from the soft tissues. So it's really difficult for us to be during the surgery doing all this manual hand-free work, because we will not do every time the same surgery, every time the same scaffold. It will be, if we do it 10 times, our scaffold will be different 10 times, and that's not predictable. And for such sensitive and technically sensitive surgeries, that can be the difference between success and failure. Another thing that was I was struggling with bone grafting procedures was that I don't really like, but this is my personal experience. Okay, this is not something, I know there is a lot of literature, a lot of scientific evidence on this type of techniques using PTFE and non-resorbable membranes. But in my personal experience, what I think is that these membranes are too occlusive. They are too closed. And so when we use this type of membranes and mixing the graft material with non-osteogenic materials, we, a lot of times in my re-entries of my grafts, I see some failures in the graft revascularization because of the occlusive aspect of the barrier, because it doesn't allow the periosteum to be in contact with the graft material very soon. And also the use of non-osteogenic materials doesn't seem to me that they allow a good revascularization of the graft material. So of course I try to, in most situations, to use the Curie technique. A lot of people, and I think most of people know the Curie technique. It is very well thought, very well developed, using only 100% autogenous bone, which has the best osteogenic potential, using cortical plates has a barrier, and the chips like cancellous bone in between the scaffold. Of course, the vascularization we get, and this is the principle behind the technique, it's amazing. But the problem is that I can't always do a perfect Curie technique. It's really, really hard working, really technically demanding. And once again, I'm human and I stress too much to accomplish always this type of results. It is something that the whole surgical team really, really, really sweat a lot to get these results. It's not always predictable. It's not always the same. And so even though I can have a few surgeries with 100% success, I struggle a lot to do it. It's not easy, and it depends a lot on the patient. If the patient has a good mouth opening, or if the access, for example, in the anterior region is much more easy than in the posterior region. And so if I could have this scaffold already prepared for the patient specific anatomy, all these surgeries would be so much easier for me. And so that's why I think that the future in bone grafting procedures is going to be producing the scaffolds. Well, we can say it's the present already, because you will see that we are doing it nowadays already. We can have the scaffold of the patient specific anatomy already created for that patient. And so I will not adapt my patient to the regular conventional tool that I have already in my office. I will produce the specific tools for each patient, for each defect, because each one of them is going to be different from others. So let's see a case. I'm running now a video, so let me know if the video is not running properly. So we can see that combining by superimposition,
Amazing.
it's good.
It's,
Okay, perfect.
yeah.
If by superimposition of the CBCT of the initial STL and also from the mock-up situation, we can combine all things together to understand what is the defect that we have, how much amount of bone we need to augment and produce, so that we have that proper amount of bone to place my implant in the proper 3D position to get my final tooth in that same position. Okay, so we have all things together, and so by 3D printing, we can print a titanium, individualized titanium mesh that is going to produce a perfect scaffold for these defects. Of course, it will allow me to save a huge amount of time. I will have to focus on uh, dealing with the good flap, a good mobilization of the flap to have a proper coronal advance tension free. So we will split the periosteum. I'm separating the muscles from the flap so I can advance the flap tension free, which is very critical for any type of bone regeneration. And now we have a 3D printed titanium mesh that is made specifically for this anatomy. So it gets fixed only in one position because it is rigid, and so we can stabilize in that position. We have the screw access holes to fix the membrane already prepared, so it's really easy to fix the membrane in two places. I'm just screwing also in the collateral sides just to make sure that there's no any type of movement. So you can see that easily. I don't need to waste time in bending the membrane, trying to adapt and make errors, because of course I would make errors on that stage. And the membrane is already perfectly designed for this defect. We will reproduce the exact amount of bone in the exact position to have bone enough for my implants to be in the perfect position. Of course, we were collecting autogenous bone from the ramus because I need for this horizontal and vertical defect to have osteogenic potential in my graft material. I'm mixing it with xenografts because the xenograft will not be resorbed, so it's going to help keep the volume of the augmented bone. This is principles that we know already from other techniques. So we can easily, by the huge porous, we can augment, we can fill all the scaffold with the graft material. And another thing I like in these meshes is that the huge pores, the huge holes, will allow me to have for the periosteum to be quickly in contact with the graft material and revascularize the graft material. Of course, for the first weeks of healing, I will need to exclude the soft tissues to not get invagination in between the holes. So I'm using a collagen membrane, but very quickly the collagen membrane is going to be resorbed in my periosteum. Is going to be in contact with a lot of extent of the graft and is going to revascularize. That's a very important thing on these time meshes and this design that allow me something that PTFE membranes are not allowing me. So after I do a soft tissue graft from the plate, a connective tissue graft that is going to help me to overprotect the incision line to prevent any exposure of this membrane, because the tissue is going to be really thick and avoid that exposition. And at the same time, it's going to provide a good excess of soft tissue for the next stages to be manipulated with provisionals for a good emergence profile. And after that, as the flap is completely tension free, we can use tension free sutures to close the flap very passively. So we can see the immediate healing. You see the provisionals that are completely not in contact with the ridge. There is no vertical pressure on the ridge. 1 month after removing the sutures. And now we are going to see, after 9 months of healing completely and eventfully, and now you see how it healed. You see a nice volume reach. You see the CBCT scan with the good graft integration, nice soft tissue healing. And now we are, after 9 months, re-entering, and once again you'll see that a very good surprise is that even though we have huge um, holes on the mesh, there's not a single invasionation of soft tissue to the defect, probably due to the good stabilization of the membrane, the blood-brain membrane after the titanium mesh. But at the same time, having these porous, look how we can easily have the periosteum quickly in contact with the graft material. So the revascularization of the graft is so much better than with other occlusive barriers. So now we are accessing the density of the bone. So you see not only the good volume, but also the density, the organization of the newly formed bone is really good, is really pleasant. And the bad news on this, and I think it's the only disadvantage of these titanium meshes, is that as they are really rigid and not flexible, we need to cut the mesh. So the mesh will not come out in one piece because it's too rigid, it's not flexible. So we need to use metal burrs and separate the mesh in pieces so we can remove all the mesh. I don't like to be doing it after bone regeneration. I don't like this titanium particles to have to clean all this up, but it's what it needs to do. So we can see a good bone organization, good density, good volume, good revascularization. And now I didn't want to screw up in placing the implants and not not having. I didn't want to have any type of deviation from the perfect 3D position of the implants. So I really try in these cases to go fully guided with the digital guided surgery. In that way, I'm going to accomplish the perfect position of my implants, not only talking vestibular palatal, but also vertically. I will have the perfect opening of the implants. So after implant placement with the correct positioning, we'll just close the flap and wait for the osseointegration. So another type of case with another type of tool. This is a very atrophic case. You can see the close-up smile, and you can see already how this fully edentless patient. I'm showing already the initial OPG. So you see this is a very atrophic case. There is no bone at all at the posterior region because of the pneumatization of the both sinus floors, and in the anterior region there is no bone at all in vertical height and horizontal width at the same time. So it's a typical case to do zygomatic implants or to have a patient-specific implant. I know a lot of complications in zygomatic implants. I know the survival rate of the clinical studies is really high, but my problem is when it goes wrong, the consequences are really heavy and are really serious. So nowadays I'm doing more patient-specific implants for such big atrophies that I can't really regenerate. So you can see this lady in the full removable prosthesis for the upper arch. You can see how the posterior right region, there is no teeth. There is no teeth because of this huge extrusion. There is a huge extrusion because of the teeth that are lacking on the opposite arch, but the extrusion is really severe. So you can see there is not even space to put teeth on the removable prosthesis, and that's why the smile of this patient is like this. So patient wanted a fixed rehabilitation, didn't want any type of removable rehabilitation. He wanted fixed. There is no bone, and at the same time there is this problem because the pneumatized sinus flora is invading the smile line of the patient. So I talked to Rui and I said, look, I have a very specific patient here. So the patient's anatomy is demanding from me to have very specific individualized device. So I have two problems. One of the problems is that I have a huge extrusion and I need to uh, get rid of that excess of maxilla in the posterior right region. I need to cut bone in sinus floor in height enough to hide this transition on the smile, and also to have enough vertical distance to have my 50 millimeters of a hybrid restoration, hybrid fix restoration. So I need first to have a digital tool plan this vertical bone reduction and to access of what is left of this maxilla to after that have a patient specific implant to be screwed and fixed on that maxilla. So what we can do here is after a good planning, you see here the mock-up STL that we plan and how it is related to the bone of the patient. So we can, after have the teeth positioning, you know already how much we need to reduce in height to fit such vertical height of the prosthesis. And so we can plan a digital bone reduction in height guided by the prosthesis. And after that, they will design this specific implant for the patient that is having only cortical fixation. So we are using the most cortical fixation we can. We are using the bone of the close to frontal bone, close to the nasal bone. We are using the palatal bone. We are using the zygomatic arches. So this patient-specific individualized implants are being used for huge atrophies where we can't use conventional implants. So we are taking advantage of the outside cortical of the skeletal of the patient to get a very good fixation. And those osteosynthesis screws are going to keep the implant in place and get a fixed implant for the patient. This is the specific implant of this patient. So in surgery, we don't have a lot of pictures from the surgery because this is under general anesthesia. So after the digital guide that helped me to cut the bone in height and get space for the prosthesis and get space for this implant, we can fix this implant in position and we can fix with the access holes already created, we can fix the implant in the position that it was planned before with these cortical fixations. So the very good thing about this implant is that they have already the threads that we can screw in multi-unit abutments on top of this fixed implant. So after this, after closing the flaps, we can have a tissue level only the multi-unit abutments like it was conventional implants. So to do the rehabilitation, we are rehabilitating like if we had conventional implants underneath the soft tissue. So the immediate loading at the end of this surgery is really quickly and a conventional one. So this is the final smile of this patient. So you see how we managed to have to have proper space to get this fixed prosthesis. So you can see how in the right posterior region there is not any type of exposition of the excess of the maxilla that we had before, because we managed to do enough reduction in height to get space for this fixed prosthesis. You can see the final OPG. And let's step into the final case. This is a different situation. So each patient has different desires, different aims, different anatomies, different landmarks. And so the tools have to be adapted to the patient. And once again, let's try not to adapt the patient to the regular tools that we have in office. So this was a patient that came to me to do full arch maxillary rehabilitation, not only to have good function, but also to have good aesthetics. Actually, he wanted also to improve the facial aesthetics, because he wanted the new smile and new prosthesis to also produce a good impact on his overall smile in the overall face. Because you can see how this is a class 3 patient, and the upper lip doesn't have the proper lip support, and also the cheeks were really flattened. So he wanted to have a better lip support, a better smile, and he was aware of the aesthetic problems he wanted to change and solve. So you can see in the intraoral photos how the patient is a class 3 patient. You can see how are the teeth. You can see in the OPG huge extended caries, and some also some periodontal issues in some posterior teeth. So we will plan a full mouth rehabilitation for the upper arch. But at the same time, what we have to be aware is every time we have these class 3 patients that doesn't have enough lip support, we always try to compensate by bringing the upper prosthesis forward in order to get the proper lip support. But let's not forget what Carl Misch already taught us in the past. He taught how when we have the teeth completely outside the bony envelope, we are having non-axial forces that are going to compromise the bone in the maxilla. So we have enough bone to place the implants, but that bone is not the same axis as the teeth are going to be to get that proper lip support. So the mechanical forces are going to overload the buccal bone in the maxilla, which is the weakest one, and so we can have problems in time. So in these cases, I try not to get the prosthesis too much forward to don't have these mechanical problems. So here I thought, okay, if we only put the prosthesis top to top and not overload the bone, which means I will not try to put the prosthesis outside the axis of the implants, and I will try to compensate lip support with another solution. And remember, the patient wants a fixed solution. So what I planned once again with Rui was, okay, Rui, please design me a device specifically to this patient that can bring more lip support for this patient. So that my prosthesis will not be responsible for giving the lip support to the patient, and so I can have the prosthesis more to the palatal, and this device is going to produce the volume for the upper lip, and also for the cheeks, because it's going to include the zygomatic arch. So you can see by superimposition of photos, we also could assess how much we would produce change in the lip support with this device. And so we produce a specific zirconia device for this patient. So you can see after the extractions, after bone reduction in height, we did a conventional Olin 4. And after the implants placed, we could stabilize this zirconia individual devices. It's a difficult surgery because it's also big flaps that are needed to have the proper space, to have the proper access to put these devices in place. So they only stabilize in one position because they are made specifically for the anatomical landmarks of the bone of this patient. And after knowing the position, they are prepared already with the screw access also to use these osteosynthesis screws to fix in place on the maxillary bone in on the zygomatic process as well. We don't need a lot of screws because these devices are not going to be loaded. They will not receive mechanical forces. They will not have connection to the prosthesis or the implants. So it's only to stabilize them. And after then you can see these voids, these huge holes that will allow the muscles to insert again on the bone of the patient. So also the muscles are going to help keep these devices in place without any problem. And these are responsible to give volume for the lip support and for the cheeks as well. So you can see the immediate loading of the patient 1 week after the surgery. We planned prosthesis on top the lower arch. We don't need to move a lot forward to make the patient class 1 because the prosthesis is not what is going to give lip support. We see the immediate post-op on the OPG, and you can see the change in the patient's overall aesthetics of the face. Of course, with a little bit of increasing of the vertical dimension, new prosthesis, everything changes, but also the lip support is totally different. The cheek support are totally different. And this is what is most important to me. See how the upper lip move forward and see how we have a little bit of bump in the cheeks that we didn't have before all this. And this is the definitive restoration in zirconia. These restorative steps were made by my colleague, Kevin Oliveira, who works with me in prosthodontics. And this is the final smile of the patient with the zirconia bridge. You can see how it changed completely, not only the smile, but the whole face of the patient. And now you can see how the position, the anterior posterior position of the lip is not supported by the prosthesis. The prosthesis is way too palatal when compared to the lip, because what is bringing the lip forward is the zirconia individualized device, and also the cheeks of the patient have more support because of this device. And this is the final OPG after the definitive restoration of the upper arch and also the rehabilitation of the lower arch. And this is another example how we can more and more in nowadays to start evaluating our patients, to access the specifications of each patient, to know the challenges of each patient, and try to make use of these digital tools to create individualized solutions that will be adapted to the patient-specific anatomy. In this way, we are saving a lot of time, we are saving a lot of troubles, we are having less technical difficulties because all things are more and more helping us for these situations, and we can focus our efforts and our stress in the things that the digital tools will never help us, like, for example, opening a flap and providing the flap, managing to have tension-free closure of the flap. That will never be done by digital tools. Well, I think not. Let's see. So thank you, guys. Thank you for hearing me again today. I hope there was no technical problems today, and any questions I will be available if I know how to answer them. But I'm pretty sure, confident that we can have good conversations on these topics. Thank you.
Thank you, Paulo. There is something that I want to talk. It's about being a team, because what you see is the final long chat that I have always with Paulo every time we are going to decide how to make it. It's not a casualty that we use zirconia implant and zirconia material for that case. Why, if we use metal, or if we use, for example, PIC, the risk of distance is enormous. Because every material where tissue doesn't attach, uh, there will be abrasion from the interior. So distance, it's a great risk. When we're using zirconia, and if Paulo, could you share with us the photo with the prosthesis, with not the definite, the provisional?
With the definitive,
No, the provisional.
this one.
Inside the mouth, yes, here.
Yeah.
I think we can almost see on transparency in the middle the presence of the zirconia there. It is so thin, the tissue, but while you have attachment from the tissue, it is really, really stable and stays like that. Um, that's not just a question, it's a question of making a team. And Paulo, he pushed me a lot. Sometimes he puts me working at Sunday, but it's true. It's really to develop good solutions. We need to discuss a lot. I remember this case. Paulo says, "I need something to boost the lip to this guy." I said this thing, you only need the lip, you don't need the thing. I don't know, I don't have the pictures here. Let me saw the pictures here. And he said, look, we have to do, and then he told me, we have to do zygoma and lip boosting. And that's it. It's always, first, it's very nice. I always say that I have a very, very good job because my job is talking every day with very intelligent people. So unless you guys that have to stay all day close working in office, I don't do that. I just passing the day talking on the phone with very intelligent guys. Well, I see that we don't have any
When
questions.
we talk in the morning, it's easier because we haven't even drank in the day. After lunch, sometimes the ideas are a little bit more confused.
Yeah, that's true. Yeah, that's true. Okay. There is no questions. Anyway, you can put the questions after to
Hmm.
Paulo. And we just want to thank you for your presence and hope to see you tomorrow with all these problems that we have on post-posting some of the lectures. But anyway, it's the virus cause. Okay. Okay, guys. See you.
Bye, guys. Thank you. Bye bye.
Bye.
Gracias.